Alrighty. Can everyone see my screen, my slide there? Awesome, thank you. So welcome everyone. I think we'll get started now that we're recording and people can trickle in. So welcome to our Co-Design Hub speaker series. If you would please introduce yourself in the chat box, we'd love to hear who you are, your name, where you're joining from, and anything else that you'd like to share with us. If you are snacking on a donut or something like that, we obviously love to hear things like that. And if you're tweeting along, our speakers have put their Twitter handles in the chat, but also our Co-Design Hub one can be put in the chat as well. And so I'm gonna just do a brief land acknowledgement while we're here. So we would like to acknowledge that the land from where this session is hosted via Zoom is on the traditional territories of the Mississauga and the Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum, an agreement to peaceably share and care for the resources around the Great Lakes. And those are two pictures, one in Niagara and one in Hamilton. So we would also like to invite you to think about the land that you're joining us from and take a moment to reflect on that as well. I'm seeing lots of action in the chat, so I love to see that. So today's agenda, we're going to do a brief introduction to who we are and what we're doing at the Co-Design Hub very briefly, and then we'll introduce our two fabulous speakers, Dr. Katie Burney and Isabel Jordan, who are going to present their work today, and then we'll do a nice Q&A. I didn't introduce myself, so I am Sam Wachinski. I am a registered nurse by training and a postdoctoral fellow with the Co-Design Hub, and I get the pleasure of working with our Co-Design Hub throughout my time here. So it's really nice to have everybody join us today. So our Co-Design Hub team is a group of researchers, trainees, community stakeholders from across a variety of disciplines and experiences such as health and rehab, engineering, business, critical disability studies, and lived experience, just to name a few within and beyond the McMaster University community. The Co-Design Hub is a multidisciplinary initiative. If you've never heard of us before, welcome, it's nice to see you. We are aimed at creating health and social service system change with structurally vulnerable populations, and we bring together a variety of different stakeholders to advance equity-based co-design. And so we do this through 4 overlapping foci, and these include engagement, education, innovation, and evaluation. And we host monthly webinars where we invite folks to share their co-design work and experience. And today we have the privilege of hosting this session and have you all here today. So preventing chronic pain is the #1 priority for youth with chronic pain, their families, and healthcare professionals in Canada. Partnering for Pain is an award-winning patient-oriented research program at the University of Calgary. And we're pleased to present Dr. Katie Burney and Isabel Jordan, who will share their innovative approach to using design thinking methods to engage youth, parents, healthcare professionals, and healthcare administrators in co-designing a new health service to prevent the development of chronic pain in youth after surgery. So Dr. Katie Burney is a clinical psychologist and assistant professor in the Department of Anesthesiology, Perioperative and Pain Medicine and Community Health Sciences at the University of Calgary, where she leads Partnering for Pain, an award-winning patient-oriented research program. She is the Associate Scientific Director of Solutions for Kids in Pain, SKIP, a national knowledge mobilization network working to improve evidence-based children's pain management through coordination and collaboration. We also have Isabel Jordan here, who is the strategic lead in patient partnerships in the Chambers Lab at Dalhousie University, as well as the co-chair for the Patient and Caregiver Advisory Council for SKIP. Isabel is the mother of a young man living with a rare disease and has drawn on her post-secondary degree in biology, as well as her personal lived experience and disability to become a strong advocate for patient partnership and research. She's been interviewed on CBC Radio, written blog posts on patient engagement, co-authored charters with the Patients Included movement, and is a member of numerous health research communities, has spoken at national and international conferences about collaboration between researchers and patients. She has also received the Canadian Organization for Rare Disorders Rarity Award and the Patient Safety and Quality Council Quality Award in Advancing the Patient Voice. It is a privilege to have you both here, and thank you so much for your time. And I will hand it off to you both, and I'll stop my screen so that you can share your wisdom with us.
Wonderful. I just want to say thank you so much for the kind invitation. It's a real privilege to be here and to learn more about the Co-Design Hub at McMaster, and to be able to do it here with Isabel is just really exciting for us to share where we are with this project. And I did put in at the bottom of each slide just our Twitter handles if anyone's interested in that, and a hashtag that we use in my lab. So Isabel and I also just wanted to start with our own land acknowledgement. So it sounds like other people have already put in theirs, which is great. I'll just acknowledge I'm in Calgary, so I'm on the traditional territories of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda, and it's also home to Métis Nation of Alberta Region 3. And that's the beautiful Rockies, not far from where I live, where we were out earlier this fall.
Hi, thank you for that wonderful introduction. I'm privileged to be logging on from the traditional unceded territories of the Squamish people, more commonly known as Squamish, BC. That photograph is taken about a 60-second walk from where I am, well, 60, let's say it's a 2-minute walk from where I'm sitting right now. I feel very fortunate to be able to live, work, learn, and play here. And I feel like I've really benefited from the teachings of the people here and from being able to grow as a person here. I know a lot of people have put in their own land acknowledgements in the chat, and I really appreciate that. If you're wanting to find out more about land acknowledgements and where you live, we put a link on the slide to nativeland.ca where you can learn more or find out about where you happen to be logging in from. It's especially helpful for the day, sometime where we can travel elsewhere and be logging on from not the same place we always log on from.
Thanks, Isabel. I just wanted to share, if you want to know more about the research that we do in my lab, or even more about this project, you can check out our lab website, and more about this project will continue to be posted there after today, in addition to some of the other partnership work that we do to address some of the top 10 priorities identified by youth with pain and their families in partnership together. So when Isabel and I were meeting to talk about this presentation, we had a brief conversation and said, gosh, what does co-design mean to us? And it was a you go first, no, you go first kind of conversation. But what we realized is actually we were not that far apart from each other. And Isabel's kind of gut instinct was being open to changing course. And where mine went to was being open to rethinking how things are done. So we come from different perspectives, but it was really interesting to hear us both bring forward that word of openness, and this idea that change is needed and rethinking, but doing that in an openness and a partnership together was something that really stuck out for us in this approach.
Kind of thinking a little further from that or deeper into that, I know for myself, I've been asked to be involved or been involved in a lot of opportunities that have called themselves co-design, but really haven't been co-design. And I think the difference for me in what real co-design is and what the message we really want to share with you is that real co-design involves sharing power. And the way that I often think about this is that power is a limited resource, and both in the real world, as we all know, but also in this metaphoric version of power that, as I always have this difficulty with that term of like empowering patients, and we're going to empower patients, because people too often say that without being willing or understanding that those who hold power, those who hold decision-making capacity, first have to give up their own power in order to make room for us to take that power on ourselves. And in order to co-design, it has to come from like the top down and the bottom up, and really take the opportunity to share the power to do what Katie just said, to change course, to make decisions differently.
That means it'll be really good.
Maybe I'll just ask anyone who's unmuted to mute if that's okay. Yeah, thanks. And so we agree here, right? And I think this is something that's really important from this position of privilege as someone who works within the health system and as a researcher who traditionally holds a lot of that power, from a systems and structural place, that we recognize that this is about kind of a sharing and bringing in new voices in a way that provides opportunity for other decisions potentially to be made. And I think, this is no surprise to people who've heard me speak or talk about this before, but I truly think that partnering with youth and families is a game changer for how we think about actually making transformational change within the health system in particular. And this paper is not a highly published paper in the greatest, highest impact journal in the world, but was shared with me by Julie Drury, actually, who many of you may have heard of or follow on Twitter as well, to really shift my language from into partnership, right? And how we think not just about engagement, but partnership, which I think is language is meaningful, and we can also get stuck in what language, means. But I think partnership for me tends to reflect a little bit more of that shared power in a really important way. And I think this is really critical to how we approach not just co-design, but I think research more generally, but also how we think about change within the health system as well. And for me, this work really started by setting priorities. This actually started when I was a postdoctoral fellow several years ago, when I attended a 3-day workshop on how to think about partnering with people with lived experience in research. And before that, I hadn't learned much about that. I didn't know much about that in my own PhD and graduate student training or clinical training as a psychologist. But I knew in that 3 days, it set a spark for me that said, I want more of this. I believe in this. I value this. Tell me more. Give me all the things. And so thankfully, with the support of my postdoc supervisor, Dr. Jen Stinson, we wrote a grant to CIHR around building a patient engagement strategy for youth with chronic pain in Canada. And one of the things we built into that was a top 10 priority setting process modeled after the James Lind Alliance approach, which is one of several priority setting partnership approaches, but it's one that's recognized for the high level of involvement of people with lived experience and healthcare professionals in the priority setting process. So it's robust, but it also promotes equity. And actually those who traditionally hold power in priority setting, like researchers, are not, they're not really included in this process. It's actually putting the power of this priority setting into the hands of people who are living or supporting people living with this every day. So we gathered national priorities. There were more than 540 ideas. We turned those into research questions. Then we sent it out for another survey to people with lived experience, so youth, parents, healthcare professionals, who rated the top, selected the top 25 as being the most important. And then this was in end of 2018, we met together in person with a purposefully diverse group in terms of geography, race, gender, age, health profession, experience with chronic pain, to reach consensus on the top 10 priorities. And this is a picture of our group in person when we did that. And I'd known of Isabel before. Isabel worked with people I knew, but this is really where Isabel and I got to know each other better. And both her and her daughter, Evie, who lives with chronic pain, came and participated as 2 of the 20 participants in this priority setting process. So it really, this co-design project I'm going to talk about today and how we prevent chronic pain really started from this priority setting partnership and this spark around patient engagement. And so our co-design project is really addressing this top priority. Of these 540 that were submitted, the number one decided on through this process was what treatments or strategies effectively prevent acute pain from becoming chronic. And so we did all of this. We were sharing what all the top 10 priorities were. And I encourage you, if you are interested in chronic pain in youth, to check them all out. They're all important. But this number one, we wanted to move forward, and we said, let's get together. Let's, figure out where's the right space to action now. Where is their readiness? Where is their opportunity to move this forward in an effective and meaningful way? And so really what comes to the forefront was surgery. Surgery, about 80,000 youth undergo surgery in Canada each year. It's only a portion of those that will undergo major surgeries, so that require them to stay in hospital overnight. But for those youth who have major surgeries due to scoliosis or other conditions, approximately 20% or 1 in 5 will develop chronic post-surgical pain. So it's chronic pain that results as a consequence of their surgery. So this is an opportunity, acute pain, that short-term pain after surgery, may be somewhat expected. We can better manage that, but we can prevent, right? This is really an opportunity for us to action this top priority to say, let's stop this chronic pain before it starts. So this surgical context is really an ideal time. It's also a time where youth may start to appropriately use prescription opioids. But if we look at that, some are still using their opioids for pain management 3 to 6 months later. So there's other risks that come with poorly managed pain in this context as well. The other part we knew was there's a gap in pain management care. So for those who aren't familiar with pain management, in some centers, pain is primarily managed in surgery and then by parents in primary care after discharge. In children's hospitals, there may be what we call an acute pain service that supports youth with pain management while they're in hospital. And then we have chronic pain services that support youth when they've already developed chronic pain. But we have kind of this dead zone for youth who are at risk after they're discharged home from surgery, when we know it's a particularly challenging time for youth and parents, where there's a gap in care. So there's a real opportunity for us to prevent and action this top 10 priority, and a real opportune space to co-design to fill a gap within the health system. So we wrote a grant together and to CIHR, which was funded, that was really focused on co-designing health services to prevent the development of chronic pain in youth after surgery. And so we have some funding from the Canadian Institutes of Health Research and the Canadian Pain Society to really move this work forward. And Isabel, because of her engagement and lived experience as a parent and caregiver, is one of a few partners on that project grant. Or on that Catalyst grant, and has continued to partner in co-designing the project, but also, as you'll see, in really carrying it forward. And the approach that we used was a human-centered design approach of these transitional pain services. And this model really fit for us in thinking about it because it closely aligns with the principles of patient partnership or patient engagement as equal members of the research team, but extends that to really bringing forward and creating space for people who are living with something, have been through an experience, to put that at the center of how we think about co-designing a service, really starting with that place of empathizing and defining the context, the situation. What is that like for youth with chronic post-surgical pain and their parents and caregivers? And then bringing all of the different stakeholders together to ideate, to find these core design principles in what this health service should look like, and to start to prototype towards that together. So the phases of our project, our first phase was to do a national survey of surgical pain management practices. So what's actually happening already in children's health centers or health centers serving children across the country around this space, and what is the health system's readiness to change practice in this area. Our second phase was to do interviews with youth with experience with chronic post-surgical pain, parents and caregivers, and also healthcare professionals from different disciplines who have expertise either from a surgical context or a pain management context or otherwise, to really start to base our co-design being informed by that lived experience, by that expertise in those spaces. So we did semi-structured interviews with youth and with parents and caregivers and healthcare professionals. And then the part we're going to focus a little bit more on today is our virtual design thinking workshops, where the original grant written pre-pandemic was to bring everybody together in person for a day and a half. which I would love to have done. And we have some reflections on virtual versus in person towards the end of our presentation. But we took this into 2 virtual over Zoom design thinking workshops together. And we also brought in some other expertise from Healthcare Human Factors, which is a group that's based at UHN in Toronto, to work with us in terms of informing and guiding our co-design process, as well as working with us to iterate, use the information we've gathered, but to iterate that in a facilitated way to arrive at an interactive blueprint for such a service together.
So one thing that really underlines kind of the ethic around how we're thinking about this is a phrase I use often, which is stay in your lane, but remember that everybody's lane is important and everybody's expertise is valuable. I mean, what happens in, I think, car racing is if people end up drifting into other people's lanes, is that there's big crashes and ugly things happen. But if you stay in your lane and remember where you're supposed to be, then things go much more smoothly. The way I think about this is that I think that phrase has been used in the past to kind of keep people from talking. But the way I like to think about it is that everybody's expertise needs to be there, but that often some expertise has been ignored, and primarily that of youth, of patients, of families. And that's often the expertise that we need to bring into it. So when we're thinking about how we did this and what we wanted to make sure we daylighted and people that we heard from is that we really need to respect and honor each expertise that people are bringing, and that they're all equally important. But also remember, and this is very much my patient partner point of view, but I think Katie would probably back me up, is that there are certain perspectives and expertise that haven't been at the table before, and perhaps we need to make more space for them. And that's, of course, that of patients and families and those that are receiving the services. I think one of the exciting things that happens when we bring people together like this from different perspectives is that it can spark new ways of thinking as we listen to one another and listen to one another with open minds and create a space for honoring these different perspectives. It can sometimes be difficult. And Katie and I will talk about this a little bit when we talk about our reflections on the process and maybe what our takeaways, or what we're not going to say what we've learned, but what we're learning. But really that piece around everybody's expertise is valuable, and perhaps make a little bit of extra space for the expertise of those who have been ignored before.
So I wanted to give you a sense of what our co-design workshops look like. The focus of our first workshop, which we had in October, was really focused on taking some of the learnings from the interviews. We turned those into some brief personas to kind of ground some of our conversation, and really focus on developing some design principles around how this health service what it should do, what it should achieve, how it should make people feel, in terms of the experience for youth going through surgery and their parents. We had 5 youth, 7 parent caregivers, 9 different healthcare professionals from different disciplines, and kind of some surgery, some pain management, as well as some health systems administrators, so program managers, up to kind of programmatic leaders at various places across the country. And we did a lot of small group work, really iterating and having some of these shared guided conversations to really focus on what the service should achieve and what the patient journey experience should be like in navigating this period of time with current existing gaps in care. We then kind of took that information, consolidated, and we did a second workshop in November, which was really intended to build on what we learned in the workshop 1, to look about what this experience should look like across different healthcare resource settings. And so one of the things that may be unique in the context or the challenge we decided to tackle is that we're a national group, and we were not just designing these services for one particular hospital or one particular institution. And that was really important for us because this is a gap that exists not just at one center, but in many places for youth across the country. And so we didn't want to just design the Cadillac version, right? That can be available in a high resource environment, but how do we also iterate something that people then at different centers can pick up and really then start to say, okay, how do I figure out the nitty gritty of what this looks like at my particular site and institution? So we also talked about, what are we learning? What does that look like in a high resource setting, like, a well-resourced tertiary care children's hospital or quaternary care kind of children's hospital? And then what might this look like in a place that doesn't have an acute pain service or doesn't have a chronic pain service already, because nevertheless, if these kids may still be at risk.
We recognized how these workshops went virtually was going to be really important in the outcome and how this process went, especially given that we went from wanting to do an in-person thing to doing a virtual thing, and that looks and feels very different. And we wanted to highlight a little bit of how having, a little bit earlier, I talked about how co-design really needs to be partnered with patients from the top down and bottom up. So we wanted to tell you a little bit about what that means and how that showed up for us in our process. And really it showed up for us in partly in how we designed these workshops and how they functioned. A little bit of what that looked like is what these workshops ended up looking like. So things like the pre-package that went to workshop participants. So some of the contributions that patient partners like me put into that is how can we do a pre-package that'll help people be ready without overwhelming them, especially patient partners, although that really benefits everybody as well, not just the patient partners. We had a welcome video, we had expectations and guiding questions. So by expectations it was, you can read this ahead of time, but you don't have to, so that people don't feel a huge amount of pressure, but some people like to be ready ahead of time. Creating ground rules that create a safe space and what that looks like for patient partners. And I emphasize patient partners because we're the ones that have more of a chance of feeling harm or trauma from sharing our patient experience from these workshops. So creating that opportunity for safety is really important in order to have our full participation in these workshops. And it was really necessary to have that in order to have good outcomes. One thing that we did that I really loved, although I know it was a lot of work, is we were trying to figure out how do we help create that sense of connection and community that you get in person when you like grab a coffee or a Danish or put your coat up and say, hey, I have a dog too. And those little moments and that, that breaking bread together. So the team put together these little snack, packs of swag that went out to all the participants by mail. So there was kind of a little communal feeling, like we all got this shared gift and we could share our snacks together, which was really cool. Another shared learning that came from patient partners was we had an icebreaker planned, which was really great. But as it turned out, it wasn't accessible to all participants from a disability point of view. So that's something that having patient partners can help you suss out ahead of time or afterwards if things don't go so well. And patient partners can also help understand what's going to be a safe way of having breakout groups so patient partners can fully participate. Did I miss anything, Katie?
No, I think that was great.
Okay. So what do these look like? And these sessions look like, and I can kind of tell you from I can tell you from lots of point of views, I guess, but most authentically from my point of view, I'll tell you, they went by really fast, really, really, really fast. They were pretty exciting and full of content. People logged on, we got split into breakout groups. One thing, we had a mural board. I don't know if people are I think probably a lot of people are familiar with it, but it's basically an online whiteboard. And what I really liked about it is that the facilitators for the breakout groups could just there's a lot of ways for people to participate. So individually, we could put things into our own into the mural board. the facilitators, we could tell the facilitators what our thoughts were on a given question and they could put them in. We could put it into the chat and they could put it in, and it just leaves a lot of room for people participating in their own way. Another thing that I think worked out really well is having the healthcare human factors, oh my gosh, my brain almost went blank there, be the facilitators for this. I think it was really important to have somebody that wasn't directly, had no skin in the game kind of thing to facilitate. And it made it easier, I think, for folks to participate. And I think it made it easier for them to create safety and to pull out participation from the different people in the group. I have a very personally, and I know it's not just me, it's other patient partners as well. I have a very fraught relationship with personas because often I think they don't reflect necessarily a full patient experience or what I might necessarily want to contribute. In this case, I think they were done really well because we had personas to guide a conversation, but there was space verbally made to use them as a guideline, but not necessarily something we were trapped into. So it really allowed for full conversation around what we thought the needs for this kind of service would be from our different perspectives. So that's how these different sessions went. And then there was also an opportunity for folks to connect if they thought of something afterwards to connect back. So I think it's really important to have a variety of ways for people to contribute because not everybody is obnoxious like me and is willing to be the first one to talk and go blah blah blah. This is all the things I think are wrong and right. It's really important to give people opportunity to contribute in ways that they find comfortable.
I'll just add, we shared that we did a pre-package before every single session as well. So between the 2 design thinking sessions and so on. So we were constantly kind of sharing back information because we were not 1.5 days in person. Our 2 design workshops were about 3.5 weeks apart. So we really wanted to provide some of that continuity in a way that maximized our time together online, because that you can't spend as much time online as you can in person working on something. I think we've all learned, but enabled some of that continuous energy and content and opportunities for reflection. We wanted to share a little bit about how these design thinking sessions iterated our thinking over time, so you can start to see some of the impact of it. This is not even the first patient journey map that we started with around how we think about the touch points with the health system. And, this was an interesting challenge from a co-design process because when you think about the surgical journey, there are many care coordination challenges and touch points with various parts of the health system: primary care, surgery, inpatient stays, discharge home, potentially school, whatever follow-up looks like. And then if you have a youth, that would be for your typically developing kind of youth who is not also involved with a number of other medical teams, right? Not also involved perhaps in complex care or otherwise, which may be relevant for some of these youth as well. So this is probably the second or third kind of patient journey where we started maybe after the first session. And where it looks now is a little bit more like this. So we're thinking a little bit more about screening. You're seeing kind of the creation of a pain point person where we're co-creating the plan, where they get referred, then surgery, then, these other touch points around discharge, how that's being managed, what this follow-up looks like, and what potential transfer to care, either in primary care or should they go on to develop chronic pain, what that looks like. So we're starting to see kind of how this moves us along and iterates, exactly how we navigate all of these challenges around coordinating care. I also wanted to show you how our design principles, or the foundation of what this service should achieve, have iterated over time as well. So this is where we started before the first design thinking session. So what came out from the interviews, what stuck out from the interviews as things that this service needed to achieve. So it needed to orchestrate kind of holistic approaches, so multimodal, psychosocial, as well as pharmacological approaches, to champion education and knowledge translation about what resources exist, to share with youth and families, for them to be a little bit more in control or aware of what's available to them in their own experience, to think about integrating seamless connections between moments of care, and to facilitate streamlined flow of information along that continuum of care I just mentioned. Where we're at now is a lot more focused in some ways. We need to give pain a home. So we need to ensure that that pain plan is consistent within the overarching pain care plan, and that youth and families know who to turn to for support. You'll see that thread about the holistic approach, but taking the whole person into account. But it's a little more specified, a little more honed in around, that personalized care that really takes into account that lived experience of youth and families in a more integrated way. That we need to empower youth and families a little bit more in terms of championing proactive care through that active knowledge exchange between youth and families and the medical team, and really looking at this, extending this across the entire continuum of care. So seeing this has changed, it's refined a little bit, but there's still some threads that it's based in some of that lived experience and those interviews from earlier phases of the co-design process as well. So I mentioned we did a survey, we've done interviews, we've done co-design workshops, we had a stakeholder meeting, yes, Wednesday. So we're still kind of actively in this process. And we're working towards a service blueprint. So an interactive PDS service blueprint that lays out kind of what we've learned, lays out, what we think are the core elements of what this service, the touch points, and how to address some of those touch points in care, such as through the creation of a pain point person and what that person's job description could look like and who might be, best filled to do that, but also principles in that, a screening tool around chronic pain for kids and where does all this information live, knowing that that may look different at different institutions, but in a consolidated, simplified way that's accessible to different managers, administrators, healthcare professionals, and thinking about what implementation actually looks like. So we take it from this co-design when we get to this interactive service blueprint, but then the challenge of implementation is also part of how we're considering this. So as part of this, we've also asked all these different stakeholders who've been engaged to, we've done a bit of a Delphi process to identify what are the outcomes that are going to be important to evaluate success in terms of implementation of such a new service, both from all the perspectives, right? The youth and family experience perspective, but also looking at that from healthcare professionals and also managers and administrators, because we want to co-design a service that can be sustainably implemented in an effective way, but that is also oriented and based within youth and family experience. So stay tuned. We'll have more of this kind of stuff into the new year as well, which we will be very excited to share. Isabel, maybe I'll turn it to you just to start some reflection.
Oh, but I wanted to go last.
Oh, okay, I'll go then, sure. So we also just wanted to end by, I think this is reflection so far. I think I've shared this is we're not at the end of this project. And I think even if we were, I think how we learn and improve within all kind of methods and partnership approaches we take, we always need an openness to continuous learning. I think some of the things that have been really interesting for me along the way is, Isabel mentioned one already, the value of partnership also, and facilitation through some of this co-design process with people who are slightly removed from the research team. I think there's benefit to that. I think we all bring a bias and a lens to everything that we do and an investment in outcomes, emotionally, academically, intellectually, financially, or otherwise. I say financially, but I'm not earning any money from any of the work that we're doing. So there's no conflict of interest there. But, just want to articulate that, I have found we had a separate facilitator for that priority setting workshop that led to some of this work, but also some of this co-design work as well. And, I think creating a bit of space, nobody's objective, but creating a little bit of that space has certainly been helpful for our team. And I think it brings in new ways of thinking about things. Again, because people who engage in co-design in many different spaces, not just in pain, brings in potential solutions and ideations and considerations from dramatically different areas, that can really lead to new ideas. The other part I wanted to reflect on was virtual versus in person. I'm really grateful that we were able to move forward this project without, and being able to do some of that virtually. But I will say I've really missed being able to do this in person. We've done a bit of evaluation about the quality of engagement after this. Similar way we had done that through in-person engagement I've done in the past. And they're still generally quite positive, but perhaps not quite as positive. And I think those opportunities when you're evaluating connection, and kind of shared understandings and those kinds of things, it's harder to do when you're just sitting in a very more formal kind of 2 hours, more focused conversation, as opposed to those informal, snacks, lunch, different things you do when you meet together, right? And you learn more about each other in that informal way. I think it was also noticeable, not everyone was able to, not all different stakeholder groups engaged us fully in the online discussion. So some, primarily those, I'll say, not youth and parents, but other stakeholders are often engaged in other things in their workday, right? Whether it's multitasking in some capacity. So I think also harder to stay really focused and present in some of the conversations. So some of that, was more notable. Not that people weren't engaged. I don't want to give that impression. They very much were, but I think it's a reflection on our virtual environment and engaging on this work virtually versus in person. Yeah. So those were some of the things I've been thinking about, lots of others too, but I'll turn it to Isabel and then we can have some time for discussion.
I think I only have 2 things to say. I could be lying. I think it's really, one of my big takeaways from this is if you're doing this right, where you end up isn't where you think you're going to end up. And that's been really interesting to me, that if we're listening and if we're really getting participation from people, it can take you on a turn. And I find that really exciting. I really like where you can see where Katie was presenting where we started, and that already wasn't where we started. It was on the first workshop was different where we ended up, and we're still going through this, so it'll change again. And I think that's a really important lesson, that if things aren't changing as you're going, then maybe you're not doing it right. Something else that I'm really thinking about, especially after our 2 workshops, is that when you're bringing people together, and this might be not an easy thing to hear, and it's not necessarily an easy thing to say, but my nickname isn't Pathologically Honest for a reason, is when you're hearing patient experiences, there can be a very big disconnect from what patients' reality is and what either, not necessarily clinicians, but what administrators might think patient experiences. And that can be really difficult to reconcile in that workshop space and make conversation difficult. It can silence people on either side, and kind of reconciling that difference. Like I think it's hard for people who work in the system to hear that patients are having a really tough time and they're not getting the services that people who work in the system think that they're getting, or are having really bad outcomes, because people are working in healthcare because they want to help. So I think it can be really difficult for them to hear from the horse's mouth that, yeah, actually it's been awful and we've had really terrible outcomes. I think it's easier to deal with that disconnect in person. I think you have more time to reconcile it. I think you have time for like the hand on the arm and the break to say, that's terrible and I'm sorry to hear that. In a 2-hour Zoom meeting, there's no opportunity for that. And I think it makes the conversations harder to reconcile. I don't have any answers to that, but I think it's something we need to think about. That being said, I really enjoyed this process. I'm glad that we could do it at all, given our current reality. But I think it's something we need to think about. Hi, I'm Debbie Downer.
No, but I think, I will say what excites me a lot at this stage is there's a real, I feel really good about where we've chosen to co-design, because there's ample readiness from a health systems perspective at many local levels, provincial levels, and national levels. So we do have some real contextual factors that actually have generated a lot of interest and reach out from colleagues who are interested to hear what we end up with, because their health systems are ready now to kind of tackle this challenge.
I agree.
And I think that's not always the case, but is something that, is really exciting for how we think about the timeliness of addressing this.
I totally agree with you. I'm really glad we're at that space. These are conversations that need support for everybody, I think. Reality is hard.
So I know we want to leave some great time for discussion, and I can see there's some questions in the chat. So just want to put up this acknowledgement slide before I put it down, just so we can acknowledge the other project team members, some really great people working across the country championing improvement of pain for children, as well as members of the healthcare human factors teams that we've had the privilege of working closely with on this project.
Well, thank you very much. I'm going to save my own thanks and reflection for a moment and prioritize time for the questions that have been raised in the chat. I'll begin there, knowing that other people might be waiting to voice a question. So if you want to put a hand up using the Zoom settings, or let me know in the chat that you'd also like airtime, I'm happy to try and come to you. I'll make as much time as I can. Thanks, Wendy. I see your hand. I'm going to start with one that was raised in the chat from Lori, asking about how do you know that co-design has been achieved?
I saw that question. That's a tough one, Michelle.
I know, sorry.
You went right for the most difficult one in the chat. I would love Isabel's thoughts on this. I mean, it's fascinating to think about, how do we answer this in a way that we can feel very, very confident. I mean, one of the ways we've tried to get at this is actually measuring and getting people to report on engagement in the co-design sessions, right? So do they feel like their voices were heard? Do they feel like it will be actioned? Some of those kinds of things. I think it's important to hear from the people who've been involved in the process, to be able to actually reflect on that. So that's one of the ways we've built it in. I didn't present that information here today, but I think that's one piece. I think I also talked a little bit about, there's the co-design and then there's the implementation. And so I think you can also achieve great co-design, but it's not actually implemented in the way that it was co-designed. So I think even if we can feel good about what we've done here, there's also an important part about that evaluation of something that's implemented, to also see whether that, adheres to some of these principles and recommendations of what came through. And so I think there are multiple points, I guess, by which you'd need to evaluate, is co-design achieved, not just at one kind of a one and done type of reflection on that question. Isabel, I'm curious your thoughts too.
Yeah, I pretty much agree with you. I think you measure this the way you would properly measure engagement, which is by asking the folks who are involved as you go along and assessing that. But I think there is a question around, I mean, as a patient partner, and I always preface that, it's important to me that what I work on, especially if I'm contributing my own personal trauma to it, is it making a change? Am I actually doing anything? Or am I just putting my story out there for the feels? So that implementation piece is super important to me. And is that important? So that the question is, when you're co-design, for me, if you're the people you're co-designing with, is that piece important to them too? So are you assessing that as well? Katie, we should talk about that.
That's true, we should.
Thank you. Brady, I noticed that you had a related question. Would you like to unmute?
Hi, everyone. Yes, I did. Thank you for turning to me. But when the question was asked, I was like, okay, this is quite similar to mine. So first off, Katie, Isabel, it's great to see you. And as always, just thank you for your, I think, both thoughtful and reflective conversation today. And I say reflective because I do, I've worked with you both, and I know everything you presented on today is very reflective of your values to be partnering meaningfully when doing this work. And certainly that showed through the presentation. So thank you for that. My question was about, we talk a lot about engagement and co-design, which I know you're both very knowledgeable about, but I was curious if you could maybe share a few further reflections or comments on the process of empowering patient partners or parent partners when doing this type of work. And I'm thinking really about, there's the engagement and there's ways to assess about how you empowering folks and making that space to not only make it safe to be empowered to have a voice, but just let that work throughout the duration of a project as well, if that makes sense. I'm really thinking IAP2 spectrum of engagement here when we're sharing decision making, but also letting folks have that expertise.
Oh, can I answer that?
Yes,
Katie?
of course. Yeah, go for it.
So, I mean, Brady, you know how I feel about the word empower, but I can tell you how it feels to me and how it has felt to me. I've been told before that I'm empowered in a project, and really I haven't been. And I've been told before, that I feel listened to, but I haven't been listened to. I think the only way people are actually empowered is when they contribute to something and then they see that contribution reflected in the work. So when they can see themselves and their contributions and their experiences reflected in the work, I think they feel, sorry, I hate that word. They know that the work they've done and what they've contributed has meaning. So I think one of the ways that shows up in the work that we did, and kudos to Katie for this, is that as we went from the beginning of the project and then through to the workshops, is circling back to the participants and saying okay, the workshop's coming up and this is how people have contributed, and this is what in those prepackaged workshops, this is what it's looking like. Make the workshops coming up in a week, and this is what we're going to be sharing with you. And then after the first workshop, this is what we were doing. This is how it's changed given the first workshop. We're really looking forward to seeing where it goes with the second workshop. So I think really demonstrating to people that what they've said is making a concrete difference in the work and the outcomes. It's not about saying, yay, thank you, although thank yous are nice. It's not about pats on the back. It's not about, aren't you wonderful for doing this? It's about listening and putting it in the work.
Thanks, Isabel. It's for me, it's similar to when we say things are both meaningful and authentic, right? It can be so subjective. So it's important to think of those processes and check-ins. So thank you.
Thank you. I have an eye on the time, and I'm not sure I'll be able to fit all of the questions into the time we have today. Wendy, I'd like to come to you. I know you've been waiting patiently.
Thank you. That's okay. I'll try to make it brief. So this is so timely for us in Windsor because we are actually embarking on a similar project, but we forgot the engagement piece. So we're in Windsor, and I've partnered with a neuropsychologist in our community to start really educating our center. We're a pediatric rehab center on how to recognize pain, assess it, and offer coping strategies to families and children we service. And I just want to throw it out there, if we can, if I can set up a call with you guys at some point, because if I hadn't attended today, I would have missed that whole engagement part, and we probably would have thought we were doing a very good job of putting something together. We never would have talked to the kids and their families. So I just want to thank you for putting this on. We are actually starting in January discussions and some training with this psychologist who also has a very passionate interest in this, and she's worked a lot at Holland Bloorview for many years. So if I could contact somebody or anybody here today just to further our knowledge and make sure we're starting on the right foot, I would appreciate that. And thank you for allowing me to ask my question. And just again, thank you so much for all the information today.
Wendy, I have a great answer for you. Absolutely. Yes, you can email me. I put my email in the chat. Anyone's welcome to email me. But also the network I do work with, Solutions for Kids in Pain, has regional hubs, including in Southern Ontario. And so we will absolutely get you connected there too, because I think it's always helpful to know and be connected with greater champions around around this topic. So yeah, absolutely feel free to reach out and we'll further connect on and make sure.
Just going to throw in, it's really important to compensate patient partners, because I have to say that in every single talk I do.
Absolutely. I'm going to try to squish in one more question before I wrap us up with some thanks and some ways to stay connected to the hub. There were some related questions, the relationships between, Emma, you're keeping me on my toes. The relationships between the people who participated in your co-design session. So were any of the youth and families in session with people that they received service from, and when youth and parents from the same families? And also, how did you accommodate people whose first language might not be English, or did that come up?
Yeah, we can tackle this quickly. This is an issue I've thought a lot about, because I think this is something people should reflect on in any engagement opportunity, period, but particularly with youth and families as well, just because there's so many power differentials and potential for dual relationships. And I think it's always best to be able to create space to separate that as much as possible, because I think we're trying, like the goal is to reduce, and as much as possible. I think could be a bit naive or idealistic to say eliminate power differentials in these settings, but I think you're always working towards that goal. And when someone is in an active kind of healthcare professional, a family relationship, I think it's really hard to voice dissent or disagreement. So I think we always need to be thinking about that. So we try not to wherever possible. It's kind of the short takeaway. And in our particular design workshops, there was really only one family, to my knowledge, that a healthcare professional on the team was actively involved with. And I think that was easier for us with this project because we were not just trying to co-design for a solution at one center. So we were able to draw from more knowledge across the country, which helped us minimize the potential for that. The way we tried to mitigate it was most of the discussion and the meet happened in small breakout groups, and those people were not in the same small breakout groups, right? So there was opportunity for the family and I also tried to have enough people with lived experience, so youth and or parents, that no one was in a group with healthcare professionals on their own. There was always at least two youth parents, whatever that kind of lived experience perspective was. There was never one person with lived experience with a bunch of healthcare professionals or administrators. I think those are all strategies we take to reduce some of those power differentials. And then in terms of the last one, language didn't come up, but accessibility came up. So in terms of communication, not just communicating verbally or creating space for alternate forms of contribution. So maybe Isabel, I'll let you speak a little bit maybe to that part quickly if you want.
Yeah, disability accessibility is a huge thing, and thinking, disability and accessibility is more than ramps. It's some people have a verbal communication difficulty. So having, and even, being on video, off videos, we had a problem in how we envisioned the icebreaker and how that went, and making that accessible as well. So, taking all those into account, one thing I really screwed up today is I'm trying to remember at the beginning of talks to do a verbal description of myself, because some people have visual impairments. So very much late, I'll say I'm a middle-aged white woman with, if you can see it, purple and green and blue hair, sitting in an office with mountains painted on them, wearing a gray sweater, and glasses. So having that accessibility piece is really important, and thinking, people don't need to disclose their disabilities. So trying to keep the ways people can communicate accessible for everybody, or asking at the beginning, do you have, before the opportunity arises, do you have any accessibility needs that we can address?
Mm-hmm.
Thank you so much. I can tell there's so much richness in the discussion here, and I hate to cut it off, but I will, to to be respectful of everybody's schedules. And thank you so much for Katie and Isabel for joining us and sharing your expertise today. It's obvious how thoughtful you've been about this whole process and how meaningful your engagement with your communities have been. So thank you for sharing your example and resources and tips and tricks. There are some links popping up in the chat for people who would like to stay involved with our hub. You can connect via our newsletter and receive information about upcoming sessions. We have one planned for February with Yuda, who is the Director of Inclusive Design from OCAD-U. So that's very exciting. We're happy to have you here. There's also a link to our evaluation as we continue to refine the educational opportunities that we provide to our community. So any feedback would be greatly appreciated. And again, thank you, Katie and Isabel, for joining us today.
Thank you for having us. Happy holidays to everybody.
It's been an absolute pleasure. Have a great day, everyone.